So for today, absolutely honored to have Nick Limbo. Nick and I go back a long way. He was my interventionist attending when I started training at Emory. I would not tell you which year it is, though, when we started working together. I don't want you all to guess our ages, but that's besides the point. But anyway, so for today, we have Nick Limbo moderating the session. We're delighted to have Jolanta Silimatilla from Austria and Suzanne Barrett from Mass General to be panelists. Akiko Mayara is well known to us. She'll talk to us about calcified nodules with imaging, followed by a case presentation by the internationally renowned Mirat Asna for Saudi Arabia. She'll talk about a calcified bifurcation PCI procedure, followed by Kevin Krause from Brigham, who is an expert in CTO, OC imaging, bifurcation PCI. We'll talk about OC imaging and discussion of a bifurcation case and talk about the MLD Max protocol. Our chat moderator sitting with me today is a famous fellow, John Lisko, who's been great and looking at all the questions, and he'll ask the pertinent questions of us throughout the program. So without much ado, I'll hand it over to Nick to moderate this session. Thank you, Nick.
Thanks, Tanvir. Our first speaker doesn't need any introduction. She's an expert on all types of coronary imaging techniques, and I've learned a lot from her regarding calcified lesions and treatment of calcified nodules. So Akiko Mahara from Columbia University.
Thank you. So can you see my screen?
Yes, we can.
Okay. So let's start. I'm talking the calcified nodule by imaging today. Okay, so this is from the same patient. We take the picture by OCT and IBUS. And the calcified nodule was defined as small calcium fragments, accumulation of the small calcium fragments accompanied with the fibrin. This is how it looks like pathology. And because of the fibrin together, we see very strong attenuation by OCT and IBUS. And this is a very typical picture of the calcified nodule and presentation. This patient was 80-year-old female and presenting non-STEMI. And by OCT, you can see the calcified nodule here. And also, when you go to the very proximal, you see the very circumferential calcium contained proximal to the distal. So always calcified nodule on top of the very diffuse calcified lesion. This is a case. The patient, they compare the patient with without calcified nodule. And if you look into the long-term outcome after the treatment of the PCI, the patient who had calcified nodule showing red, having the worst outcome compared to the without. And in this Japanese study, they show the patient had instantly stenosis. At the time of the event, they evaluated by IBUS, and they show 82% was actually reprotruding of the calcium into the stent. So this is how it looks like in the autopsy case by the pathologist. You see the stent, and you see the calcium in the plaque, but also that calcium is protruding through the stent. This is how it looks like reprotrusion of the calcified nodule as a cause of the stent failure. To answer what type of the calcified nodule is bad, we ask ourselves, and we including about 10,000 cases. And we look at every cases, and finally we found very clean calcified nodule about 250 cases. And half of them was eruptive calcified nodule, and half of them was non-eruptive calcified nodule. And this is how it looks like angiographically. Both type, angiographically, you can see the radiolucent mass. You can see here, and you can see here. This is how it looks like by OCT. Eruptive calcified nodule, you can see the irregular surface on the top. And then after stenting, you see the nice stent expansion, and actually stent area is very round shape. And this is because of the eruptive calcified nodule can be redistribution of the calcified nodule because coming from the small calcium fragments and then can get the good stent expansion. On the other hand, non-eruptive calcified nodule, the pathologist call this is so-called healed calcified nodule. And you see the surface, that's a fibrous cap. After stenting, looks like non-calcified nodule site is stretching a lot. And then we just pushing the calcified nodule, and that's how it looks like the mechanism of the stent expansion. And many times the stent area is okay, but the stent shape is really oval shape. And then we ask, using the acute stent expansion, what is the important morphological findings to associate it with the stent expansion? Eruptive calcified nodule compared to the non-eruptive is actually good stent expansion, but other findings is actually more important, such as how big the calcified nodule indicating post-stent expansion. Non-calcified nodule site amount of the calcium is important to predict poor stent expansion. How thick the calcium in non-calcified nodule site is important to predict poor stent expansion and negative remodeling at the site of the calcified nodule. So when we are treating the calcified nodule, not only the calcified nodule itself, how it looks like other site. That's actually more indicating the stent expansion after treating the calcified nodule. And then we ask, what is a long-term outcome? And I was quite surprised. Actually, the outcome is completely opposite than what I expect, meaning the eruptive calcified nodule is almost 2 times worse outcome compared to the non-eruptive calcified nodule. And this is case example such. So this is a very nice radiolucent mass by angio. OCT show the eruptive calcified nodule. And we put the stent, and you see the nice stent expansion. Patient coming back 5 weeks later because of the staged procedure for the LED. But when we took the angio for the right coronary artery, you see the radiolucent mass at the exact same place. And then when we took the OCT, we see the reprotrusion of the calcified nodule. But I was a little bit doubt. This is really the calcified nodule or could be red cell thrombus. And then we took the IVUS and we confirmed this is really the calcified nodule. And we decided to put more stent. And you see that again, nice stent expansion. But again, you start seeing already there is a reprotrusion of the calcified nodule. This is how it looks like the mechanism of the stent failure of the calcified nodule, especially the eruptive one. Afterwards, this patient was okay and now is doing well. And this is overall summary of a cohort. Dark red or dark blue indicating the lesion at the site when they come back, there is a radiolucent mass indicating reprotrusion of the calcified nodule. Light red or light blue indicating no radiolucent mass. Number 1, you see the more event in the eruptive calcified nodule. Number 2, if coming back early, they are more likely radiolucent mass indicating reprotrusion. And then they come back late, we don't see that radiolucent mass indicating the non-intimate aplasia. And then we ask, what is the important morphological findings to associate it with the long-term outcome? Eruptive compared to the non-eruptive associated worse outcome. And also how big the calcified nodule is also associated, and also the angulation, meaning how big the hinge motion at the site of the calcified nodule is associated with a poor outcome. However, good stent expansion is important, and when we have the good stent expansion associated with a better outcome.
Akiko, was there any procedural related factors of whether atherectomy or IVL was done, or are the numbers too small?
Okay, yeah, answer is number 2 small, but we see some sort of the trend doing the atherectomy could associate it with a better outcome, but still we have not clear idea yet. Okay, so this is my final message. This is actually quite important. When we look into the calcified nodule, we are overestimating the stenosis many times by angio. This case, you see the almost like subtotal occlusion of the distal left main and very scared. But when we analyze by angio, it's super small lumen diameter. But OCT, it's actually not. When we compare the measurement between the angio and OCT, this is a discrepancy. The blue color indicating angiographic radiolucent mass. Number one, if you see the radiolucent mass, most likely those are the calcified nodule. Number two, if you have the radiolucent mass, more likely big discrepancy compared to the angio and OCT. So therefore, this is quite important because once we start treating the calcified nodule, they are poor outcome. Therefore, before treating, it's quite important to confirm that's causing the ischemia because many times angiographic appearance overestimating the stenosis. So to summarize, the calcified nodule is frequent in the mid-right coronary artery and distal left main. I didn't show this data, but that's true based on our other data. And also, there is a two type of the calcified nodule. One is eruptive, the other one is non-eruptive. And compared to non-eruptive calcified nodule, eruptive calcified nodule has better stent expansion by redistribution of the calcified nodule. However, when we consider the long-term outcome, eruptive calcified nodule has worse outcome because of the reprotrusion of the calcified nodule. Thank you.
So do we have, the panelists have any questions for Akiko?
Yes, so I would like to start with a question. So really congratulations, extremely intriguing data, I think. And do you believe that the stent type or radial force of the stent might play a role in the stent, in the nodule protrusion during the follow-up?
I think so. But we have to remember how much we are covering by stent slot onto the surface of the plaque. Actually, like probably around like 15% if we consider the surface. So actually stent itself, whatever the stent is really we are not covering enough. So that's we have to consider. And maybe some like the novel idea of the stent, meaning more covering of the calcified nodule could be better. That's one idea. And in terms of the radial force could be true because how reprotrusion is not only the amount of the surface coverage, but also the hinge motion or mechanical stress making the reprotrusion. So having enough force could be better or even the other way around because making more fracture. Those are the questions which we should be answered.
I think Kevin had a question. Kevin, do you have a question?
Yeah, I think it was pretty similar. Akiko, great presentation. Thank you as always. Sometimes when we see nodular stent failure, it's just I always wonder if the stent scaffold is given way, I think similarly, or if this is just reprotrusion. Every once in a while, it looks like on stent boost, the stent metal looks compressed. Do you have any imaging insight into that? How often it's just reperfusion versus maybe the stent fails, or is it? It's always tough to see by the IVUS and OCT, I find, but you guys are so good at this. I thought you might have some insight.
I'm sorry, your question was? I'm sorry.
Yeah, does the stent metal ever fail, or is it always just protruding through?
Oh, okay. Yeah, sure. That's exactly what I show, meaning like we have two different types of the calcified nodule. And then more likely, like more fragile or non-healed type of the calcified nodule, we can make the good stent expansion, but they are coming back. More likely reprotrusion. But already like the even similar calcified nodule to start with, but already surface was healed and looks like they are almost like one stone. Those are, we are just pushing in one way, and then geographically you see already one view is not very good, but the other view is good because always the eccentric stent expansion. And those are probably we ended up under expansion if that is small artery, and then that's causing the stenosis, restenosis, not because of the deep protrusion, is more likely small stent area.
Great, thank you.
I think we need to move on to Mirvat's presentation.
Well, thank you for having me. I'm just I'm going to load up my presentation here. Right, so I think you can see my slides. I don't have any disclosures that are relevant to this presentation. This is a 62-year-old woman who presented to our hospital with an acute coronary syndrome. Her risk factors included diabetes, hemoglobin A1C in the 2 digits, which is not uncommon in our part of the world, unfortunately. She's also hypertensive and hyperlipidemic. Comorbidities, she is overweight, has chronic kidney disease, COPD that required admission about twice in a year, and peripheral vascular disease that required some endovascular repair. So this was her echocardiogram upon presentation, a little bit of left ventricular hypertrophy, mild hypokinesis of the anteroseptal wall, but overall LV function is preserved. And surprisingly, this is her angiogram. So there's significant calcification in the proximal segment. It almost looks like there's a tube over there of stents, and very slow flow in the LAD, and a large circumflex territory. So this was the areocaudal view. So we had a multidisciplinary team meeting, and we usually have those in the cath lab, especially if the patient is being cathed during the daytime. We call the surgeons in, and we had quite a discussion because we do feel the targets are actually good. It's a heavily calcified lesion. We will have to stent back into the left main, but with her comorbidities, they really did not want to take this patient, and with the slow flow, I think an immediate decision had to be made for this kind of patient. So this is a fluoro. It's going to be a little difficult for you to see, but before we're able to do anything, we wired both vessels, and we won't be able to do any kind of imaging without establishing some kind of flow in this patient. So we took a small balloon. This was a 2.0 balloon, just to establish flow, and the aim was, once we establish flow, to deliver a imaging catheter, and then proceed with some form of atherectomy. So we did do her radially, and this is the balloon being inflated. As you can see, I mean, it's a very small balloon. We tried to deliver an intravascular ultrasound. We couldn't do it. Part of the reason is probably because we were not very coaxial, and this was not a very supportive guide. In hindsight, we probably should have used a better supportive guide to get better imaging. So we managed to get a few images from the IVUS when we were initially trying to get it in where it got stopped, but you could see there's significant calcification. It's circumferential, quite superficial, which means it needs to be addressed. We were a little better aligned when we managed to get the OCT catheter, and I think it isn't about, I mean, it's open to the panel, of course. It does appear that OCT catheters are perhaps smaller, but they are also very flimsy and not very supportive. So actually, sometimes they're more difficult than IVUS to deliver. So I don't think it's about size. I really do think it's about the guide catheter, whether we had a buddy wire or some sort of support to help us deliver. So the images that we ended up getting from the OCT run, so this was obviously done after we did some initial pre-dilatation. You can see all sorts of calcification. You do see superficial and deep calcium in the LAD itself. It is circumferential. You do see the tightest segment. This was the Ultreon that gives you automated calcium quantification. So the tightest segment was extremely tight. This was after a little bit of dilatation. As we kept going, you see a little better lumen, but significant calcification throughout, even as we go more distally. Almost, 360 degrees, both deep and superficial. In order to strategize, it was important to visualize the circumflex. Now, she's not normal, so we went ahead and did a OCT of the circumflex as well. You do see calcification, but when we do sizing, and unfortunately I don't have the clip with the sizing, you do see a decent lumen. And so in this kind of a patient, we opted for a more conservative approach. So really, it started with what appears to be a 001 Medina classification, where it's really the ostium of the LAD, the distal left main was okay, and the circ ostium, as you can see from the OCT here, is also okay. But you will need some kind of atherectomy, so that was clear. What we do see is we're trying to maintain wire in the circumflex. Part of it is to maintain access because we will need to stent back into the left main. And part of it is to maintain guide position, to kind of anchor us a little better. We're delivering a microcatheter just to exchange for a stiffer wire that's going to give us a little more support to rail things in. At the proximal segment, we were able to deliver a shockwave lithotripsy, which we ended up doing in the proximal segment of the LAD back into the left main. And then we opted to do orbital atherectomy slightly more distally than that. And I think there was a lot of debate on what to choose and what not to choose. And part of the reason was we wanted to dilate the segment that was diseased, but in hindsight, we probably should have delivered the IVL more distally first and then back into the tighter lesion. Because once you've inflated the shockwave, it's a lot more difficult to deliver. Orbital was easier to deliver subsequently, obviously. So we did OCT again post-treatment. So post-treatment, you can see dissection planes, which is exactly what we want to be doing. This was done with the shockwave atherectomy, IVL lithotripsy, I'm sorry. You can see around 8, 9 o'clock. And slightly more distally, you do see again about 8 to 9 o'clock, slightly longer segment. And then what you see down here, this is where we did not the IVL, where we did the orbital atherectomy. There's some lumen gain, some shaving off that you see from the OCT over here. We always end up doing balloon angioplasty after these kind of treatments. So even after IVL, we do high pressure balloon angioplasty, as well as with the orbital or rotablator. We always do polishing balloon angioplasty of the vessels. And so this is what it looked like. Again, it's very difficult to appreciate what's happening without intravascular imaging when there's just a truckload of calcium. We opted to go ahead. We took the length and size from the OCT imaging. We're going to take different positions just so that we make sure we're back. So this is a cranial shot that's helping us position the stent into the left main across the circumflex, but going into the LAD and starting at the ostium. The image on the right shows you that we do have our wire trapped in the circumflex, and we are expanding, and the stent is expanding very nicely over here. Oops, sorry, gotta go back. So over here, we're doing proximal optimization, and as we're pulling the guide back for proximal optimization, you know, the wire, I try to keep the soft part of the wire that's being trapped. It just makes it easier. You avoid having loops and difficulties. But actually, we did end up losing it as we were taking the guide out, which tells us we were a little undersized in the left main and we need to do a bigger proximal optimization, which is what we did next without a wire in the circumflex. So we did post-dilatation of the stent, more proximal optimization, and then went ahead and rewired that circumflex and ended up doing more OCT imaging. So this was the OCT imaging again, post-stenting, and you can see that now we have a well-expanded and a post-stent. I don't think we were well calibrated, so I don't believe this is the correct size of the stents that you see here in green. But you do see well-opposed and expanded stent in the left main and in the LAD. Some more positions, off-axis views to just look at that circumflex. It's very difficult with calcium and stent to appreciate it. But you do see in the areocranial coming off at 90 degrees the circ ostium, and it's nice and clear over there. So we opted to be minimalistic. You do see diffuse disease in this patient, and we can just keep chasing our tails with her. And just wanted to get this kind of a patient with very slow flow off of our table, and then consider optimizing her. She actually did exceptionally well and ended up going home. She was readmitted a year and a half later with very atypical symptoms. But given that this was a very complex procedure, we went ahead and lowered our threshold to do a relook angiogram. And as you can see, the circ ostium remains free of disease, and the stent in the left main and LAD again is widely patent with no issues over here. And aside from atypical symptoms, she really was doing fairly well. I am going to stop and kind of open it to the panel and see if you'd opt for 2 stent strategies, if you'd, I mean, I think it is a difficult call, and sometimes it's more than anatomy that we end up judging when we decide if we're going to keep it as minimalistic as possible.
So beautiful short-term acute result and an excellent 1.5-year result. Can you tell me, I was a little confused. You went in and you dilated with the 2.0 balloon, then you went straight to IVL?
So we dilated with the 2.0 balloon just to establish flow and then put in an OCT catheter so that we can get some OCT imaging, and we saw that there was calcification. At that point in time, we went ahead and took actually a slightly bigger balloon than the 2.0 so that we can deliver the IVL. I did skip that step. I didn't actually show it to you, but we did go with a 3.0 high pressure balloon and dilated there. And then we took the IVL shockwave, which was actually a 3.0. And the mistake that I had done was I dilated proximally with the shockwave. So when I wanted to go a little more distally, I couldn't advance it anymore. So I just had to kind of use it in the proximal LAD and distal left main. And then distally, it was a choice between using more shockwave or going with some other atherectomy. And I think we just debated it amongst us and opted for orbital atherectomy. In hindsight, I probably could have gotten more leeway from that shockwave if I delivered it more distally first and then did shocks more proximally.
Yeah, most people try to that do the combination of the 2 procedures with atherectomy and IVL usually do the atherectomy first to try to debulk as much as they can, and then IVL to kind of stretch out any of the deep calcification. But excellent result. Any other questions from the panel?
There's a general question from the chat. In calcified nodules, is the morphology of the nodule changing anyone on the panel's approach to atherectomy, be it eruptive or non-eruptive?
So I think we defer that to Akiko, and I have another question for her. We always talk about stents for nodules, and I'm just wondering if when we do some kind of debulking of nodules, now we have the era of drug-coated balloons, and we do know that there are issues with radial force of stents and so on. Should we be considering something like drug coating after debulking or some form of atherectomy in nodules rather than stents if we don't have dissections distal or proximal to it?
Yeah, I think I agree. Meaning, like as I show, like the behavior, acute behavior is quite different compared to the eruptive or non-eruptive. But somehow difficult to say which one the other because sometimes mixture. But I think the majority of the calcified nodule is non-eruptive. That's more likely probably atherectomy is necessary. But if that is majority was non-eruptive, you try the balloon, and if you really redistribute of the calcified nodule and good lumen area, maybe non-stent and looks like the drug coating balloon could be a good idea because putting a stent anyway come back. If so, why we have to put the stent or maybe worse? So I think those are the debate which we should consider.
Yeah, well, panelists have questions. Jolanta, followed by Suzanne.
So, congratulations, Mirvat. Really beautiful result in such a complex case. I have a question considering the lesion preparation with the balloon. What's your algorithm using balloon size, which is 1:1 for the planned stent, or is there any situation you would choose one size less, like 0.5?
My concern for downsizing is you will still be able to deliver the stent, but it may not necessarily expand. So it doesn't give you adequate stent expansion and modification. But if I plan subsequently to use another device, so if I'm planning IVL, if I'm planning rotablation or what have you, yeah, I may start with something that is smaller, just so that I can deliver, for example, a shockwave But afterwards, when I'm done with either the shock wave or the rotablation, what have you, the more definitive dilatation that I do is 1-to-1, where I do try to get a proper polishing. And I have been surprised in the past. So we used to do that a lot more than when we used to do intracoronary imaging. Now, when we're doing intracoronary imaging and we see the fractures in the calcium or lumen gain and so on, it's a little more reassuring to let you know that the stent is going to expand well. But I would say 5-6 years ago, when I wasn't routinely doing, intravascular imaging in the middle of the procedure and just kind of doing it either at the beginning or at the end, I definitely try to get a balloon that's 1-to-1, make sure it expands really well before I bring in the stent.
And one additional point, just because I'm old school and learned PCI before any imaging, was always one trick, and I'm sure everyone does this as well, is look at the 1-to-1 balloon in the calcified lesion in 2 views. Sometimes it looks well expanded in an RAO view, and then you flip it around to an LA view and it looks like a flat pancake, which you would see on imaging. But that a little bit ahead of time tells you probably haven't gotten a great result, because you can get fooled with a 1-to-1 non-compliant balloon in 1 view. So I always look at it in 2 views.
I think
Go ahead. I think along that line, actually, as well, Nick, I think it's important to actually use a longer balloon. I've certainly also gotten fooled as well. If you're just putting the long lesion and you put a 12 balloon in and it looks like it's expanding, but the reality is you just haven't made it long enough to actually see that it would dog bone. So I often will make sure I choose, I don't go for a particularly short balloon unless I'm really trying to focus my force. I guess the question that I remember about, that was an absolutely beautiful case with an absolutely wonderful result. Certainly you and your team should be congratulated for that. The question that I was going to ask is, as you were thinking about, you really clearly thought out carefully whether or not to go down a 2-stent strategy result. Did you, after the case, did you do any sort of carina modification of the circumflex and the LAD, any kissing balloon to stretch struts, or did you feel that everything just kind of looked good as it was and they were able to leave it alone?
That is a very important point. I am more inclined to do a kissing inflation. I think the evidence shows there's no penalty in doing it. And it kind of opens that strut for you, especially to a big circumflex like the one that we did here. It was a generous circumflex. And so it is nice to make sure you open up your path into the circumflex for future access. I did not do it this time, and I think part of the reason was this was not a very controlled environment. This is a patient who came in with very slow flow in the LAD, kind of acutely decompensated, and I wanted to be as minimalistic as possible and take her off the table, with the plan of bringing her back for further optimization if need be. So actually the plan was to eventually bring her back, and sort of like an investment procedure, just get her safely, get flow into her main vessels, and then maybe bring her back. Fortunately, she did very well, and we just reconsidered that plan of bringing her back routinely anyway, to do that kiss and maybe a final pot, and she did well. And when she came back in a year and a half later, that circ ostium looks like it was still fine. Again, I chose to just kind of leave that woman alone for now.
So in the interest of time, we'll go ahead. Okay, Kiko had something, but we'll get Kevin to load up his slides as Kiko asks the questions.
Yeah, this is not a question, comment, meaning I have 2 comments. Based on the imaging standpoint, like your case is really nice demonstration. Whenever you see the calcium, it's not like the focal stenosis. Although angiographically starting the osteal LAD, there is actually diffuse calcium. And then many times we focus the lesion, but we forgot the mid segment or adjacent segment. And then actually both are all calcium. And then ended up that segment or adjacent segment could be the small stent area to finishing. So I think you are right, meaning that not only the ostium, but also the mid LAD, that's diffuse calcium, have to taking care of everything. That's actually very important. And then that's, I think, the key of this type of the case. Number 2 is circumflex ostium. When we look into the circumflex ostium, it's actually like OCT standpoint is like natural stent. good lumen area and good calcium. That cannot make the carina shift easily because there is enough calcium. So actually, I saw by looking at the OCT in the circ, looks like that's really good indication of the provisional stenting. That's my feeling. Yeah.
Can you hear me okay? For some reason,
Yes, go ahead.
I transiently lost the audio feed. It's back now. Can you see my slides?
Yes.
Great. Thanks for the invitation. Great panel and a lot of friends. I really appreciate the honor to be able to speak tonight. Tanvir and colleagues asked me to talk about intravascular imaging, MLD Max protocols for imaging, and left main PCI, which I was very happy to be invited to do. These are my disclosures. I think, it's not lost on this audience that left main PCI should be supportive of intravascular imaging. This is a meta-analysis which demonstrates that lots of important things that we care about, like cardiovascular mortality and all-cause mortality, are better when left main PCI is image guided. And so I think it's one place in current practice where doing a PCI without image guidance seems unconscionable. Thinking about the benefit of left main PCI, it's not just enough to do it. You really have to do it in a goal-directed manner. Intravascular imaging for left main intervention can be focused on 3 areas: whether to treat, and we won't go into that data because it's a little bit complicated tonight, but we'll focus on how to treat and how to understand whether the stents are optimized. And so thinking about how to treat, I was asked to focus on MLD Max, which is one of 2 algorithms for using intravascular imaging to guide intervention. The first step is to do a pre-PCI imaging run, which is allowing us to strategize, understanding the morphology of the lesion, the morphology of your landing zone, determining a length by imaging, which is a much better way to do it than by angiography, and really defining the diameter quite well with IVUS or OCT, because we know we can choose diameters much better with intravascular imaging with much higher fidelity than we can with the angiography alone. After the stent is placed, we want to make sure that the stent is optimized, making sure there's no major dissections, we've got reasonable apposition, and expansion is good. We looked at this in a study called Light Lab, which was done with 40 operators across 12 different centers. And when you use the MLD Max strategy and compare the intravascular imaging data to how you would have done the case if you only used the angiogram, it changed our decision-making 80% of the time with important stuff like how we prep the vessel, what diameter stent we use, and how often we address underexpansion. So it's not surprising that there's an overwhelming amount of data now that intravascular imaging drives better outcomes because we end up making stents bigger and not leaving dangerous things behind. So thinking about MLD Max, I think probably many people are familiar with this, but I'll just go through it relatively quickly. We'll focus on how it might apply a little bit differently to left main PCI. The first thing to understand is the morphology of the lesion. Really thinking about, is it lipidic, fibrotic, or calcified? Akiko gave us a nice summary of state-of-the-art with nodular calcification, but we know with calcified lesions, they tend to impair stent expansion. It's also important to understand your landing zones. You want to land in normal when possible, or fibrotic if that's all you can find, but less often we try really not to land in lipidic pools because we know those are associated with edge dissections, and they're also associated with restenosis at the edges. Determining the length is done, trying to find normal segments, and the diameter is determined either by OCT for EEL or by IVUS, at least in diffusely diseased segments. I tend to use mid-plaque to mid-plaque. The other thing with regard to left main PCI, which is important with the intravascular imaging, is it helps us to understand strategy and technique. We can make decisions about provisional versus bifurcation stenting, and it can also allow us to understand which bifurcation stenting technique we might like to apply. Things we also consider are disease location and things not shown with the imaging, such as the bifurcation angle and the territory size. And I found it really interesting that Akiko is going to be able to predict that there wouldn't be plaque shift based on the imaging, which is a new way I'll look at OCT in the future. Akiko, thank you. And so after we sort of plan the case based on this standard strategy, we want to kind of understand with detail what the morphology is. These are two seminal papers which have allowed us to have intelligent conversations about what constitutes actionable calcium. They both come from Akiko's group, and at least in our lab, we use them every day. You can score calcium now by IVUS or by OCT to understand when it is appropriate to use plaque modification, with the idea that if you don't, when you have scores of 2, 3, or 4 on IVUS, or when you don't, if you have a score of 3 or 4 on OCT, you're unlikely to get good stent expansion. And so finally, calcium signatures have been married to something we know which is really important, which is stent expansion. And we can finally have an intelligent conversation about when it's appropriate to use IVL, rotational atherectomy, or orbital atherectomy. And so this has been a recent advancement that's been sort of put in our practice over the past 18 to 24 months. And so when we're thinking about MLD max, the M in morphology is to understand the calcium as it relates to stent expansion. So once we get a stent implanted and post-dilated, the next part of imaging becomes to ask, is the PCI optimized? The steps for this are to make sure that there's no major medial dissections at the edges of the stent. We understand apposition to the extent that it can make it difficult to recross, although it's not a major driver of MACE as long as the stent is well expanded. And I think the holy grail of outcomes is understanding the stents are well expanded with hoping to get 90%, but at least 80% expansion with the minimal stent area, holding the artery open to an approximate 90% of the reference area, proximal and distal. And so this is an important point of knowing whether your stents are well placed to understand what your expansion is. And this is easy to do by IVUS and by OCT, either manually or some of the newer systems are able to do this automatically for you. And so once we're able to understand that the stent is in, we can talk about what constitutes an MLD max optimized PCI. The M is no major medial dissections. We worry about ones when they're greater than 90 degrees, involve the media, and are certainly at the distal edge where they're more dangerous. We look to see good apposition and expansion that's at least 80, but preferably 90%. The other thing we could look at is this is an OCT data set which shows you why stents fail. Small stents fail, landing in distal or proximal reference disease makes them fail, as do distal edge dissections. And so this really creates a scenario where we know these things create stent failure. We want to make sure in our optimized PCI that they are not present. And so that's what we're looking for in an MLD max optimized, goal-directed, protocol-driven PCI. With regard to left main stenting, it gets a little bit further deep because we know in the post-Excel era that we want to achieve optimally areas in the stent of 6 in the circ, 7 in the LED, and at least 10 in left main. And so when we talk about what constitutes a left main optimized PCI, these are the things we're looking for. And so I have a couple cases I'll share which show application of MLD max to left main bifurcation PCI. 78-year-old gentleman, class 3 angina, slightly reduced EF, did not want bypass surgery, had an LAD CTO with left main, left circumflex disease. And our plan was for LAD, left circ, and left main PCI. There's collaterals to the LAD, which I'll show you in the next shot from the right coronary artery. So in this particular example, we tried to get into the proximal cap of the LAD using a series of CTO techniques. The IVUS was actually helpful in this case because we used it to mark the proximal cap for proximal cap puncture. And using a series of escalating wires and an angled microcatheter, we eventually were able to fold a knuckle over into the LAD and convert it to stingray antegrade dissection or entry, confirming luminal position with right to left injections here. At that point, we got it into the LAD in a place which we knew we were luminal. It was time to start reconstructing it. The IVUS is helpful in these cases because it helps us to identify where we've re-entered. You can see here, this is a pullback in the LED, which shows that we're subintimal for a long course. You can see the subintimal position there with the IVUS catheter in the subintimal space and the lumen on the right. Again, I have this false lumen as shown here, false lumen, true lumen. And this helps us to define where this is where we want to make sure we stent at least past that, which is right about this area. And so with that in mind, we got a sense of what our distal landing zone should be for length and what it should be for area, and started to move forward to reconstruct the LAD in this patient. We figured as we looked at the calcium portion of MLD max, there was a nodular, but actually by the fact that we went around most of the calcium, we found that there wasn't that much calcium subintimally, and our balloons expanded well. And so our calcium score, a little bit by the fact we were not really in the lumen, and a little bit by the fact that there was just a nodular segment, ended up being benign enough that we did not need to do aggressive atherectomy or IVL subintimally in this case. So with that in mind, with a calcium score of 1, we got good balloon expansion. And then we had to deal with a couple bifurcations in this example. We had the OM1, the circumflex, which is sizable, and the left main itself. And so we decided to take a double DK crush, somewhat painfully, because it's a lot of steps here. But we DK crushed the OM, the circumflex, and then did the same thing to the left main and the LED. Unfortunately, I was having a hard time finding the ostium. I tried the IVUS market, but the IVUS really didn't want to deliver well. So I put it where I thought it should be, and I hung the stent way too far out into the aorta. And so luckily we have osteoflash in our lab. I was able to remediate that very quickly. But if I'd actually used the IVUS a little bit more deliberately, I probably could have avoided that. So with that in mind, we're thinking about, are we optimized? We made sure there were no major dissections in all 3 limbs on IVUS. There weren't any at the edges. The apposition was good. And we made sure that we had good expansion per the Excel criteria, post-Excel criteria I talked about. And here's just the final IVUS of the LED into the left main showing our expansion. So I have another case, which I'd be happy to share. But before I go into that, I'd love to see if Nick, Kiko, or any other colleagues have suggestions or comments on the case I presented.
That was an excellent case. I was going to ask you a question, and I think that may be related to your next case. You got a calcified nodule in the left main.
Yeah, actually, the next case I'm going to show is an OCT-guided left main stent failure case. So it's a little bit more of MLD max as it applies to a complicated problem, which we're unfortunately seeing more often in our program. But happy to answer any questions of dealing with nodules. The particular nodule we saw in this case was not that big, was actually dealt with by the fact we'd gone around it. So luckily our expansion and dealing with it was fine. That's not always the case though, because we do have to do subintimal plaque modification with some frequency, which you have to be a little bit careful with because the subintimal space, although it's somewhat compliant, can be a little bit more likely to rupture if you go too aggressive with sizing or with aggressive devices.
I guess mine then would be a hypothetical question. So say you had a Medina 111 calcium nodule in the proximal segment of that in a left main. So you got a left main eruptive calcified nodule, calcium in the LAD and circumflex, so it's 111. What, we talked a little bit about using stents that had extra radial force and maybe extra scaffolding that Akiko mentioned may be helpful. But what would be in a 111 calcified nodule proximal, what stenting technique would you apply to that?
I talked to some colleagues in Europe about frustration with both acute and early stent scaffold failure on nodules, having personally had a bunch of these. And when you put a high radial strength stent in and it gives and sort of fails immediately from its scaffolding, it's definitely frustrating. Canvas Makieshi told me that sometimes they'll take in these cases, if you put a DES in and it folds back on itself because it's not strong enough, they'll actually use a bare metal renal stent because they have much higher radial strength. They don't do it a lot, but in cases where you get acute failure, sometimes a second high radial strength stent, a Megatron with a second Megatron added, or, these guys and gals are telling me that they'll actually take stents from the periphery that are 4.0 and 5.0 to deal with it. And so I think Akiko's inkling is right. If you use a better scaffolding, a stent in that situation, potentially with better radial strength, you get better outcomes. I've had a nodular calcium that I've modified with IVL that has made a Megatron fold on itself at acute implant. I put a second Megatron in and it held it open until the date the patient's doing okay. But you bring up, a relatively substantial pain point with these is that our current devices and our current atherectomy tools don't always get enough compliance chains that we're able to get good expansion at, even at the outset, or, if the patients come back later, we see that they fold.
Yeah, that's because, from a theoretical basis, if you didn't have a high radial strength stent, with theoretically a culotte stenting technique, be better in that proximal segment to give you two overlapping stent layers in the left main with the calcified nodule. You'd have more stent radial force possibly and less open struts, and versus doing a DK crush in that. It's just kind of a theoretical question that I don't have the answer to.
Yeah, at least where it's double scaffolded in the left main. And you bring up a good point, because if you look at the way that this osteoflash works, we've done some benchtop testing. It actually folds multiple cells in toward the ostium. So in right coronary artery nodular stent failure, I kind of like this tool actually, because it tends to pack more metal in the place where the stents tend to fail, both nodular in the right coronary artery and also because there's an increased number of muscle bands which tend to compress stents and cause scaffold failure. So we're going to try to see, with some benchtop stuff, if flashing these things helps, because I like the way you're thinking, Nick, is that more metal potentially per unit area in the artery may help that scenario, but we don't know the answer at this point.
The two panel questions.
So I will start. Kevin, really very, very nice case. What I think very challenging in the clinical routine is the fact that those patients with a calcification are very sick. So very often they have renal failure, on dialysis, three-vessel disease. So I had several cases when I always aim to do a pre and post PCI imaging, especially with OCT, where I can gain more information. But due to the contrast media volume used, and the patient in several cases became hemodynamically unstable, having pain and so on. So for some reasons, I did not perform like this post PCI imaging where the angiographic result was like satisfactory, although I always aim to do this. So like in your opinion, is it always, important and to do the post PCI imaging, or do you know also cases from your clinical practice where the final step was not possible?
Yeah, Kiko and I have poked each other on this point, because a lot of the protocol-driven approaches to post-PC optimization are such that if you don't have great expansion, we want you to take a 1-to-1 sized NC balloon to 18 or 20 atmospheres for 20 or 30 seconds. And at that point, I think in the interest of safety, if you're not at the place you need to be, let's say you're hanging around 74% expansion, you want to get to 80 or 90, when I know I've done what the protocol suggests I should, sometimes I'll skip the third imaging run to check to see if it works, because I know I'm not going to do anything differently. And so, to your point, in the clinical scenario always drives decisions. If the patient's too sick and can't tolerate you mucking around with more catheters, I think the better part of valor is to be measured and be done. But even in cases where I know I've sort of taken the devices to where they're going to go based on what's suggested by these protocol-driven stenting image approaches, I'll stop and not do a final run. But Kiki always jokes to me that she wants to see if it worked, especially when we send stuff to her core lab.
I think totally agree what you said, but I think if you have some doubt or some sort of the concern angiographically, and then if your IVUS OCT cannot pass, that's actually super bad sign. There is a reason not to do so. So in such, actually you have to do more. Except like you're very comfortable. I just did the final touch up and then I don't think any issue. That's probably okay not to do so.
Okay, let's go on to second case, Kevin, if you can.
Yeah, no, I'm sorry. I have a question. Wait. I think by the way, go back to your calcified node. I'm not very sure that was calcified node. That's actually quite important. Don't overreact, because your wire was in the subintimal space and you are looking at the calcium from the subintimal space. And then all calcium is start with the deep side. And then any kind of deep calcium looks like that, because we are looking at from the subintimal space. So I think it's really important when we look into the after CTO procedure, when you are subintimal, how it looks like the calcium in the plaque always looks like the calcified nodule. So I think I'm not sure that was because you are subintima. We are just looking at the deep side of the calcium in the plaque. That's my comment.
I appreciate that, because that's always you teach me things. It looked like a nodule, kind of walked like a nodule, and quacked like a nodule. So that's what I thought it was. But understanding I'm in a different space and how to read these from the backside is helpful. I appreciate it. I have had very vexing cases, as you know, I'm sure your colleagues have, where we go subintimal and still balloons don't expand in a very nodular-like way. That's irritating, because we're supposed to not face this when we go around these things, but it happens more often than we like. And I typically use subintimal shockwave in those cases, and it seems to behave pretty well. I don't know if you have any thoughts about it. Subintimal rota and laser are things I try to pull as little as possible. If we can get it done with IVL, now that's my preference. Great. Thank you. Thank you. So this is a case of left main stent failure. It's a 64-year-old gentleman who's quite overweight. He'd actually had LAD PCI 10 years prior. We didn't have a lot of details on this. 3 stents were placed in his proximal LAD, and he had circus ischemia on stress testing. These are the films that I got initially, and you can see, especially in the caudal, because he's so obese, despite being in my good CTO lab, I really couldn't tell too well what was going on. And so we went ahead and did physiology of this. This was one of the more fun IFR cases I've ever done, with all the little dots stacking up such that they went off the screen in the ostial circumflex. So it quite nicely showed me where the problem was. So we went to apply MLD max to treating this patient. I think understanding whether it's going to be single, left main to circ with a crossover balloon out, or if it needed bifurcation stenting, was what we were hoping to ascertain. This is the LAD OCT, which shows the old stents. And as you look in the long view here, you quite quickly see there's a bunch of malapose stents hanging in to the left main. So the prior operator had hung about 5 or 6 millimeters of stent into the left main, which was going to complicate a little bit what we needed to do. You can see that the proximal LAD stents are markedly undersized and underexpanded with a substantial amount of neoenema. And you can see the struts in the left main here, which are quite thickened because they're 10 years old and they've got tissue which has grown on them. And luckily, by nothing more than dumb luck, I was actually able to get both of my wires through the center of this, which was quite nice to see on the OCT, because if I was outside in substrut, it would have complicated potentially gear delivery. So after we pre-dilated the circumflex, we did a similar run of OCT, which demonstrated more sort of fibrocalcific osteocircumflex disease, but this was nothing that I was worried too much that wouldn't expand with usual ballooning. And so we had a pretty good idea. I'll go back real quick. We've got an osteal segment of the LAD, which is imperfect, diffuse LAD disease that I wasn't inclined to tackle, stents hanging into the left main, and then we need to treat the osteal circumflex. So this had some impact or bearing potentially on what type of stenting strategy you take. And so, the length by MLD max criteria, the circ was 33 with a 3.5 distal diameter. The LAD length to where it sort of got to a more normal lumen size was 18, with about with 3.5 distal from what I could tell looking through the LAD stent struts. And so with that in mind, maybe Nick, I'll go back to this picture. We've got stents into the left main, a sick-looking LAD, and we need to treat the circumflex. I'd be interested in terms of what the panel and colleagues would do to treat this patient.
Well, I'll jump in and give my opinion up first. I think this is really a perfect example of how, imaging really helps, right? Because you wouldn't necessarily have known how much that stent was hanging into the left main, but that absolutely is going to change your decision making. Where if at some point you were considering maybe some sort of provisional stenting into the LAD, if you were thinking about that, I think this kind of makes you think less about that, because you're going to end up having interaction of your stent going back from your circ to your left main. So I think from this, I would certainly be thinking about a 2-stent strategy here.
That was my thought to you, Suzanne, is, looking at this stuff folding across the LAD and the fact that the LAD was sick already, I was thinking I'm going to try to remediate the bifurcation. He was a young guy. bypass surgery might be in play, except that until I crush the LAD, I don't have enough LAD disease to warrant that at this point. And so, there wasn't need for a limited LAD. So I figured we were just going to treat him with bifurcation stenting. And if that fails, if done well, then we'd refer him to surgery down the line if we're not able to keep this open.
And I think I would as long as your wire now is through all those undeployed stents in the proximal segment of the vessel, probably go in there and tap those up first. So you may not get as lucky the second time going through there with additional gear.
Yeah, and the IFR wire just happened to wire luminal into the circ, and similarly luminal into the LED. Akiko, you could be on center strut here. And then a little bit of bearing in terms of, with a pile of metal in the left main already, DK crush or culotte was something that we spoke about. Any thoughts from the panel?
I don't know, ever since Margaret's been at Columbia, we've been flipping from DK crush to more and more culotte. So I'm going to kind of err and say culotte on this one.
Yeah, I thought it would be easier to not fold metal in one direction or the other and have to go through multiple layers, having inherited some layers already. And so, the problem with culotte is that getting the ostia big can be an issue, but I think with double crush culotte, we're getting better at that. And so I thought a little bit about the hazard of this problem here with DK crush. If you treat the LED as the side branch, you're going to have a lot of metal folded across it. And similarly, that metal is going to fold across the circ. And so the hazard with culotte is that you have to pull your wire and you can lose a branch. So if I stent left main to circ, I've got a big LED stent target. So I've got very little chance I'm going to lose the LED, especially because the LED is not tight. And so we opted for...
Kevin, you already have a part of stent striking out. So if you do the first kiss, like in culotte, should be able to smoothen out the stent stress hanging out into the left main. It should smoothen that area and should help. Then rewiring will not be a problem. So I think this would be very reasonable for a DK culotte.
That's what we decided to do also. So this is a pretty savvy audience. I won't belabor this too much. We further pre-dilated the circumflex. We stented it. I think much like Mirvat said, I left the soft part of the wire there, despite the fact there was a lot of metal that tends to behave okay. After stenting the circumflex, we just took a little test angio to make sure there was no distal edge dissection. That looked good. We potted. We recrossed, as you can see in the upper right panel. We did our initial kiss with 3-5 balloons in both limb for the DK culotte. We placed our LAD stent. We potted again. We did an angio to make sure things looked well. And then we went ahead after recrossing, more kissing, a 4-0 pot optimization, our angiograms here, and then we repeated the OCT into both limbs. And this is the hazard point of culotte and DK crush. Getting the pent leg openings to get big is the hard part. My new stent went to right here. All of this stuff that is imperfect is inherited. We decided not to treat. You can see on the lumen profile, the left main is large. We've got a reasonable, not perfect, but reasonable 87% or so expansion here. And so it's good considering what we started with. I'll let this play up. You can see here. But, being attentive to areas of 6, 7, 10, as we talked about, is an important part of it. And we seem to get reasonable expansion and reasonable left main sizing. And, again, this is a little bit tough, especially in the LED, because getting multi-layer stuff now to expand well is hard. This is the OCT result in the circumflex. You can see it tapers quite nicely, and the ostium looks pretty good. And so by way of summary, using this, we were able to make the criteria of 6, 7, 10. This is the final result, and I was pleased in terms of being able to get these expanded to a place where I'm hoping to keep him free from MACE. Any thoughts or comments on that? I have one just sort of quick summary slide. Intravascular imaging for left main PCI, lesion severity. You can consider MLA greater than 6 as a place to defer, but often it's good to add physiology to that in conversations we don't have time for tonight. For PCI planning strategy, MLD is important. It helps you understand where the disease is and if you can get away with 1 stent or 2, and it also helps us to understand plaque morphology. And for post-PCI optimization, you want to make sure we've got good expansion with goal-driven areas for left main PCI and no major dissections. Thanks, everybody. I appreciate the opportunity to be here tonight.
But thank you. We've gone over time, but I just want to bring out one thing. All our organizations, ACC and SCAI, really want to promote our women cardiologists, and it's not really something it was planned in this way that we'll have women interventionists on this program, and there are 4 of them, and we want to promote our young women colleagues, particularly the women cardiology and all-in-one program that Jolanta has, and with Roxana Meran. So I think it's very important to promote you all, and hope more of you join us, interventional cardiologists. Jolanta, do you have any comments to make? I know you and I talked about it in Poland. Do you have anything to say?
Yes, so I just would like to say maybe huge thank you for this organization. Women as One has a big aim to promote talent in medicine in general, but also to support female cardiologists, and gives a lot of opportunities for all interested women in cardiology and in interventional cardiology too. So many of us can develop also skills. I participated in some programs of Women as One. So I think would like to encourage everybody to be a member, because yes, that's the way how can we support each other. And thank you also for inviting us.
So it was by design that we invited you and Suzanne and Akiko and Mervat, and thank you for being our partners and colleagues. And certainly all other guys like Nick and I, we really would want to see more of you, and certainly Kevin and our new generation of people like John. We should encourage all these people to join. And thank you very much for being part of this group tonight. And thank you all for participating, and Nick for moderating this program, and Kevin Mervat to presenting very nice, fascinating cases. Thank you so much. Thank you very much. Good night.